hapa Nawakaribisha sana katika viwanja hivi vya Navigate na semina yetu ambayo tunategemea kwa nayo leo. Naamini kila mtu atakuwa na package yake ya semina ambayo itakuwa na kalamu na kiratiba na program yetu na kinote kwa ajili ya kuchukua notes na kalamu. Naamini kila mtu atakuwa yuko sawa na tablet yake kama kuonyesha utambulisho wa nani yuko kwenye semina hii. Karibu sana na kwa muda mrefu tunao wageni kutoka sehemu mbalimbali na naomba nitawatambulisha kwa makundi hapa kwa mmoja mmoja na nitambulisha. Kwanza tuna wageni ambao wametoka Bethsaida, Msoma.
Habari za asubuhi. Shikamoo mkubwa. Mimi naitwa James Chirani, nimetoka Tanzania.
Karibu sana James. Karibu sana James. Kuna wageni wametoka Shirazi. Kentio. Karibu sana.
Habari za asubuhi. Hii kwa majina nimeitwa Mimi.
Karibu sana. Kuna wageni kutoka hospitali ya wilaya washiriki semina hii hawajafika na hiyo watajitambulisha wakifika kwa wakati, lakini tunao wakili kutoka CSMT ambao ni council team ya halmashauri. Ninaomba amalizie kwa kutambulisha kwanza watumishi wa yuko Navigate. Bodi wanaume. Karibu sana na bodi. Tunao wageni Can you introduce yourself in front of the participants?
I'm from the Netherlands
and anatoka Uholanzi na atakuwa pamoja na hapa kwenye video atakuwa na sisi kwa kama wiki sita au nusu miezi miwili hapa kwa masomo yake ya English. Dr. Maya, karibu.
Asante. Habari zenu? Wakupa shikamoni. Nimefurahi kuhudhuria. Nafikiri wote tumenifahamu. Mimi ni Maya Chirangi, niko Msuta Chiragi na sasa ni mgeni kwa ajili ya kutoka shiriki ya Friends of Bethsaida na pamoja na James na Edgar tumeandaa hii seminar. Na kuna wengine kule Uholanzi, sasa yeye yuko online, anaitwa Nadine, pia ameandaa hii seminar.
Asante sana. Dr. Mara, kwa pengine kabla ya presentation tutapata maelezo mengine mengi zaidi kuhusu nini Dr. Mara anafanya na namna gani tutapata nafasi. Tumejaribu sana wageni kutoka FMC na pili ningeomba ndio nafasi wakati tunatoa opening remarks tuweze kuzungumza kwa ndani zaidi. Karibu sana maestro.
Habari za asubuhi. Naitwa Tabora, mratibu wa pamoja asiyeambukiza.
Karibu sana. Tumemlezea DMO kwa sababu ana nafasi yake. Kama mnaona kwenye program yetu na miongoni mwetu watakuwa ni presenters katika mada mbalimbali. Lengo kubwa la semina hii ikiwa ni kuona discuss risks of cardiovascular diseases, what we do and what we think needs to be done as far as prevention of the cardiovascular diseases are concerned. Feel welcome na tutategemea kuwa na semina nzuri ambayo itakuwa ni ya kuinteract. Kuna watu wengine leo ndio mara kwanza tunakutana na Mary hapa kutoka Shirati. Kwa lazima tutumie nafasi hii kujua vizuri na kupata mengi. Sisi mko tuwe free to interact na kila mmoja maximize use of the available resources ambao ni human resources and the other resources ambao tutakuwa kwenye semina yetu. Karibuni sana. Kwa maneno mafupi naomba nimkaribishe kabla sijamkaribisha DMO, labda niseme kwamba tutatumia Kiingereza kwa sehemu kubwa na pengine tutabadilisha lugha Kiswahili, lakini kwa sehemu kubwa tutatumia Kiingereza kwa sababu kuna watu participants ambao wengine wako online kutoka Uholanzi huko ambao wanafuatilia kuweza kuona tunapoendelea kwa amefly nao wakiweza kutuelewa. Kwa hiyo naamini kwamba watu wote hapa tulioko tuko focused na Kiingereza na tunaweza kutumia vizuri katika presentation zetu. Na niombe sasa kwa nafasi hii nimkaribishe DMO atatambulisha, lakini atupe neno la utangulizi kuhusu semina yetu leo, alafu tutakuwa tunaenda moja kwa moja kwenye wasilisho hapa. Karibuni sana. Karibu sana daktari.
Kufungua haya mafunzo kabla ya kufungua mafunzo haya ni tambua uwepo wa mishishi hospitali ya mbele geti, lakini natambua uwepo wa kiongozi lakini pia tambua uwepo wa baadhi ya fasiliteta wengine hapa inaonekana bado hawajafika serikali wengi, lakini pia kuna eneo kutoka nje ya halmashauri, maana ya Soma. Au yote tuseme kwamba cardiovascular diseases imekuwa ni magonjwa ambayo mwanzoni tulikuwa tunapiga kama ni ya mataifa ya nje. Kwa sasa ni moja ya magonjwa ambayo yanaathiri sana jamii yetu. Na sisi kuna vichochezi vingi sana ambavyo viko kwenye jamii sisi kama tunapata kufuatilia kuishi matatizo haya. Nadhani tutavitambua ili kusaidia jamii ambao, kwa mfano ukiangalia za takriban kesi 1,400 ambao sana ni 0.6 wagonjwa wote ambao wanapitia ushauri walikuwa na diagnosis ya ugonjwa moyo pamoja na presha. Lakini kwa ukiangalia nani all of the attendants, 1.9% diseases. Out of them, kwa na hiyo na mwanzo sana Tanzania 0.6 kwani moyo pamoja na ukiangalia among nani diseases, hypertension and vascular diseases, 60% accounted for vascular diseases. You can see the magnitude of vascular disease in the map. Hiyo kuna kazi ya kufanya. Ukiangalia sasa ndani katika ndoto ile ya zaidi pia awareness one of the issues about needing to fight and awareness of non-diseases in our society. Pia ya mgonjwa hasa hypertension na ugonjwa wa moyo ni kubwa zaidi kuliko hata hizo ambazo ziko kwenye kazi ya kufanya kwamba tunajenga uelewa wa jamii, lakini pia tunahakikisha kwamba tunaimarisha screening and diagnosis, kuhakikisha kwamba kwenye hiyo, baada ya kusema hayo, niweze kutamka kwamba haya ni mafunzo rasmi ili tuweze kuwa active kwa michango yetu kwa ajili ya kuboresha huduma ambazo tunatoa. Asanteni sana.
Naona makofi kama hayatoshi hivyo. Pashe, kila moja pashe. Tupiga makofi matano. Pasha. Piga. Asante sana. Nafikiri sasa mpaka neno kutoka kwa kaimu na mkuu wa wilaya, tumeelezwa takwimu kadhaa za magonjwa yasiyokuwa kuambukiza. So please allow me to switch in English so that those who are online can understand what we are doing. So as the district medical office introduced, we have significant number of patients with or clients with these cardiovascular diseases, and we are having a lot of complications related to cardiovascular conditions. So we have Dr. Maya. She's going to present on the risk factors for cardiovascular diseases, and actually we have been having the cardiovascular risk management project here at the hospital, which is being under Dr. Tan, who is coordinating the project, and it's being funded by one of the Dutch Mennonite organization, and it has helped a lot in the part of screening, care, and follow-up on patients with cardiovascular-related mobilities. So you will hear later on the course of our seminar to what we've been doing and how we've been doing as far as the cardiovascular diseases are concerned, and what we think that we need to do, what we urge as the healthcare workers to work together and do all that we can to make sure that people are as far as the cardiovascular diseases are concerned. So, please, Dr. Maya, welcome. Maybe we can have a bit of maybe self-introduction before you proceed with your experience and care with the conditions, and then we will proceed with the presentation. You're welcome.
Thank you all. Welcome very much on this seminar or on this.
Sorry, kabla tuendelea
Very nice, very much welcome all here. This is not the first time we do a seminar on cardiovascular disease. I think now we started about 2 years ago with Project Cardiovascular Disease in Tanzania. So some of the data we have today are coming from the project. It's still, I think, the reason why we started having change. And we see that the increase cardiovascular disease and there are very less possibilities to get treatment. I think most of you have known that sometimes people are just suddenly dying, falling down, no pulse in the room. For sure, I'm almost sure most of those cases not knowing why dying probably are cardiovascular diseases. And that's why a few years ago we found a need to look on it via and started some workshops, units, well, conflict of interest, and it's always obligated in the Netherlands. It's about accredited schooling. We need to show that there's no economical interest. I cannot pay by funds. pharmacist about some drugs or things like that. I have there's no sponsor of the research data or the data we show. Next, this is my content of my presentation, and mine will be like overall with later on having a program with more going specific. I want to share a little bit about cardiovascular disease and risk factors, but not go into the details very much, but also give some ideas what we can do to prevent. And I always like to end with something to take home. You should remember after this. It's increasing the cardiovascular diseases, and it's on the moment the number one cause of death in the non-communicable diseases. Worldwide is the highest number of deaths are coming from cardiovascular disease, and it's increasing in Tanzania. And there are a lot of risk factors causing this we can prevent. And that is something I would like you to take home after this meeting today. If we started on the literature, we say that we see that the percentages of adults having high blood pressure is in the, according to the literature, is 26 to 28%. But even here in the area, we found higher numbers. As I said, it's the number one killer worldwide, which is the numbers of 2023, 70.8 million deaths every year. And the most we always thought cardiovascular disease is a disease of the Western world, but 75% of those deaths are in developing countries, in middle and low income countries. You can see here in the numbers are much higher than cancer, much higher than respiratory disease, and also much higher as HIV. It's really a worldwide killer. Next. If you look at Tanzania, because we have different problems here, the top 5 of cardiovascular disease, hypertensive heart disease is number 1. And we know hypertensive heart disease, which is much related with the main cause of heart failure. But we also have valvular heart disease and coronary heart disease. There are people with cardiomyopathy, and on number 5 is the rheumatic heart disease. And of course, other cardiovascular disease, which I think in the hospital we see more. And if we look at top 5 and in the community, are stroke or peripheral artery disease. Those, I think every time I'm here, I see this patient with stroke and peripheral artery disease. Next. The common cause of heart failure in Tanzania, as I told you, is hypertensive heart disease, and there are like 3 degrees. And there is no left hypertrophic ventricle, but there is a diastolic dysfunction, then we call it degree 1. You can see on the head, the picture shows a little bit. Then there is when you start to have some hypertrophy, so the muscle becoming too thicker, but it is without dysfunction. And then it's the 3rd degree, then you have congestive heart failure, and it can be with reduced ejection fraction or without. And why we make the difference between those two is because of the medication. Some medications are known to help with reduced ejection fraction, and some medications are known not to help. So to know the difference, you make the difference. And then there is the peripheral arterial disease, which shows that there is, there we have like, it's an obstructive arterial disease, and it has 5 stages. Stage 1 is asymptomatic, means people have obstruction but they don't have any complaint. Stage 2A is mild claudication, and that means they have a little complaint when they're walking, but not very severe. Then there is the moderate to severe claudication. And then the stage 3 starts with the ischemic rest pain. People have pain in the leg while they're not walking, when they're resting. And in the stage 4, we have the ulcerations or the gangrene. Then the stage, and there's only the possibility of amputation. One of the things we can do for early detection is measuring the blood pressure on the arm and measuring it on the leg and dividing it, and then you get an ankle brachial index, which is helpful to know if there is any peripheral arterial disease. And it's a very simple tactic, and one of the workshops today will do a little bit more going into this topic and also do some practice of it. Because I think if you can do this, you can know before it might be, and you can start treatment. Risk factors. I think some of you already know, but it's also to make a difference between modifiable things we can change, a healthy diet, inactivity, tobacco use, and also alcohol use, but also the intermediate risk factor: overweight, obesity, hypertension, raised cholesterol, diabetes. Modifier, I put them more in division, like they're also modifier. We maybe not think about very much, like air pollution. And stress is a very modifier. But the non-modifier are genetic factors. For example, if one of your near relatives had a young stroke or a young heart attack, there's a risk you as an individual might have a higher risk of having a cardiovascular disease. So ethnicity, there's a difference between tribes and communities. Here I put again all the risk factors, the traditional risk factors we all know, but also for low-income countries or middle-income countries, we know there is a relation with infection, inflammation. We know there's a relation with poverty, although we don't understand it quite well. And there is a relation with industrialization, air pollution. In areas where there's more air pollution, we see more cardiovascular disease. Hypertension, we say there are 3 different grades. Hypertension is, and to say somebody has hypertension, first you should measure it not once. You have to have several measurements to say this is hypertension. But there are different grades, like grade 1, that is the 140 to 160, and then we say grade 2 is 160 to 180, and grade 3 is above 180, or diastolic, we can also say is above 110. And very important is how you measure blood pressure, because if you measure blood pressure when somebody just came from exercise or when he was not resting, then you get another, so it must be rested in rest, and at least you should have 2 measurements to calculate between. Again, the grade 1, but when we talk about hypertensive crisis, usually we say, when there's hypertensive crisis, what is the target? We said the hypertensive crisis is when people have complaints, like they have problems with seeing, they have a headache, and they're very high in hypertension, like above 200. So sometimes it's necessary to treat that with IV medication. In diabetes or in elderly, we take other targets. For example, if you are diabetes and you're less than 60 years, we say we target a lower blood pressure because we know it has a better outcome on cardiovascular disease. And if there is albuminuria, which means there might be kidney failure, usually advised to start an ACE inhibitor. Above 60 years, we usually take the targets a little bit higher, because we know it's also common to have higher blood pressure when you're a bit older, the stiffness of the vessels. And also we have usually another choice of medication. And the first choice, for example, in elderly is calcium channel blocker. But still, the ACE inhibitor can be used also with elderly. Then a little bit on diabetes in Tanzania. We know there's a quite high prevalence on the numbers of the World Diabetes Federation. It's now 9.8% in Tanzania, and that means that there are people with diabetes above the age of 20. And in total, they estimate, because we don't know for sure, there are 2.9 million people with diabetes. They also estimate there are lots are undiagnosed. They are there. They have been screening in some areas, so they calculate that to see the undiagnosed. And you know there is a big relation with lifestyle, like obesity, smoking, alcohol use. But, and that is very new on the moment, there's also a big relation with childhood malnutrition. And I think it's this year, this spring, the World Health Organization, also the International Diabetes Federation, they announced that there is diabetes type 5. It's recognized now. For years they were thinking there was a relation between young children having malnutrition. In Europe, they saw a relation with the people who are survived World War II, and we saw an increasement of diabetes. But now they really saw there's a big relation between malnutrition and the chance later on to receive diabetes. So food, and we will see today, food is an important subject in prevention. But it starts it starts in the beginning. It's not starting now. It starts also in children. If they are malnutrition, the chance they get diabetes 2, or we consider diabetes 2, but now we say is diabetes type 5. Later on is much higher. Yep. Tobacco use. This is what we know in the moment, that about the prevalence, the percentage of people smoking, adult smoking tobacco is 40%, and it's much higher in men than in women. According to research, it's related, high level of smoking related with low level of education and poor economic status. And it's a major risk factor. Not depending on your economic status. I think whenever you see any patient who's smoking and having cardiovascular risks, he can take all the medications that are in the world, but there is no better reduction than stop smoking. And besides that, smoking is also a big risk factor for other non-communicable diseases like emphysema, bronchitis, and lung cancer. It's like I said, it's associated with increased cardiovascular risk, prevalence, and there is one. We'll go to the next. What can you do to prevent? And these are, I think we should take away what is this day. Yeah? No smoking. I put it on number one because it's really a high cause of cardiovascular disease. But there's more, because a lot of people who are not smoking and still get cardiovascular diseases. Daily physical exercise is a main issue to do to reduce. Healthy diet. We will talk about that later in our session. We know high fibers, low fat, and low salt are 3 key issues, but there's more. There's more. And there was even very interesting research done in Tanzania on the big effect of changing from traditional food to modern food and big effect that had on this disease. The reduce or to stop alcohol use is also a main factor to prevent. You can treat available risk factors like hypertension and hypercholesterolemia. Stress reduction and sufficient sleep are very important. All, I think, goes together with awareness and early recognition. Cardiovascular disease are present because the main risk factors are hardly recognized. People are walking around with diabetes, not knowing. People are walking around with hypertension. We saw some yesterday in the elderly care department, and they come with other problems, and you think it's something like malaria, but they have a very high blood pressure. Awareness is early recognition. And that's, I think, one of the main reasons. Anyone you see in OPD, he comes for malaria, he comes for something on his food, something not related with cardiovascular disease. Better, just, I think it's very good to take blood pressure, to check. It's also a good way of screening. Anyone who comes to visit the hospital, you do a screening, and it doesn't cost much, even if you have no screening programs. The good news for Tanzania is that the real traditional food, the food of the lake, from the lake, the food but with a lot of vegetables, and the food doesn't have a lot of artificial products, actually is the best food to prevent cardiovascular disease. It's the new food, the one they sell, the produced with all the added things, which also add to the risk of cardiovascular disease. So, and here I think one of the best is that those foods are not the most expensive food. If you fresh fruits, the vegetables are much more available, and people can harvest them themselves. So, exercise, I think you get the chance today to experience yourself and hear more, but as a doctor in the Netherlands, I usually that everyone should at least 30 minutes a day do exercise. And it depends on your age whether that should be heavy and making you really tired or just low. And it can also be done. Exercises are also possible for older people. Right? When people are not walking, they can still do exercise on the chair. There's lots on the moment going on air chair exercises, and even domestic activities can be part of your exercise. And we will hear more about it today. Physiotherapy, I think, is also a very, very important issue in that. We're very lucky here to have a department. I think it can be used more. And that's why I'm very happy in Shirazi. I know they already included the physiotherapy advice in the cardiovascular project. We probably hear more about that later. Then the healthy Tanzania that I wanted to share with you because this is a very recent research they done in. I think they done it in Kilimanjaro together with the University of Nijmegen in the Netherlands. And they looked at the traditional Kilimanjaro diet of Chaga people, which is rich in plant and fibers and whole grain, beans, green vegetables. And they also have the mbeke. I don't know what it is, but maybe some of you know. It's a fermented banana drink. And what they researched, they saw that the diet itself had a big change on information and a real direct change on risk. It's published and well, it's also a randomized controlled trial. Well, I wanted to share that with you because it's something they looked about it, and the Western diets, I think they compare with what usually you can buy here, like chips. And if you want to know more, the link is also in the article. And that is did in the screen this spring a little bit on we kind of make a post to show people what is now healthy food, or that you have a quarter of a half of your plate is vegetables and fruits. I always tell people in the consultation room. And if you want the fish, it's possible to add the fish is good. But well, more on diet issue will come later on in this today in one of the presentations. Yeah. Communication. We'll have some of that today also, but there are a lot of things how you can communicate, and I think how you communicate also makes the difference. Because when people get your advice, they need to be convinced, they need to follow it. And there, your communication skills are very important. Because why should I take advice from you? And that's something to look about. How do we communicate? And I think maybe also to develop a lot more about today. How can we communicate? Because if people are not convinced themselves and they're not seeing that it's important to change, they will not change. We have in the Netherlands a lot of experience with motivational interviewing, but I heard it's also coming here. Can be helpful to use pictures and flyers, which I think also is important to know about health beliefs and to understand that and give notice to that during your talks. If you don't, probably your message is not reaching. And counseling, we always talk about the 4 A's, counseling for behavioral change: ask, assess, advise, assist, arrange. Something maybe to go deeper into in a later stage. Coming to the end of my presentation, I would want to share again that it's one of the top causes of death and a major challenge in Tanzania. Prevention is possible by reducing risk factors. I'm very much convinced. And lifestyle, food, there's a lot of things still possible. Also, I think, look on your app, tomorrow is Health Diabetes Day. Yeah, World Diabetes Day. Probably also will have some place where there is free checking for diabetes and most welcome, because I think also awareness is not only for the people but also for our staff. Know your own health, know your own pressure, and live what you explain to your patients. I think that's very important. But most welcome also to join in the screen or to be screened tomorrow. So far, that was my presentation. Are there any questions or additions from your experience? I know a lot of you have already are working on this issue and have guests sharing later on that introduction. No questions? No questions?
Yeah. We should feel free to ask, talk in any convenient way that is okay with anyone. So if someone feels like maybe you cannot talk in Swahili or in English, you can also talk reply, and then we can have the translation for you. Make sure that you are interacting with what is happening. Please welcome for any question or any concern. And have the information that the tea is there. So please, we just utilize the just a few minutes here, and then we go for
Yeah, well, and
for
on the
tea.
end
So
of the day also we have the possibility to ask questions to all the people who are here. So maybe if you have no question now, but later on you think, oh, I want to know more about it, you can still ask a question. Like you said, you can put in Swahili, translate or and for the, I think for the logistics in the room where we're China, there are also the papers with their right for the workshops. Because after this we have one presentation, and then there are workshops. So please subscribe for the workshop. After your presentation, you will explain where the workshop should be.
Thank you for doing the presentation. My concern is a lot of findings has been done concerning this cardiovascular diseases related to lifestyle and food. But I think also concerning with the cardiovascular diseases and maybe the overuse of some drugs or not to use in the proper way some of the medications.
Maybe that's when you are having, and there are also some risk factors we didn't talk about there, like for some vascular disease, some drugs of abuse, they also have a big effect on cardiovascular disease. And of course, if you are prescribed medication and you're not taking it accordingly, or you're not prescribed accordingly, you still have high risk factors. That's why we have a workshop on hypertension treatment. A lot of people with hypertension medication still have high blood pressure. So it's also have to prescribe the medication right, also to instruct people to take the medication accordingly. That's I think part of prevention. I don't know if you knew that or not. Yeah, it's very important that if people are on medication, they take it accordingly. If you go deeper on this, very fancy, high cost blood pressure medication to somebody who cannot pay that every month, you for sure know that he will not take it every month. And if he is on, but we can talk about that in the workshop on hypertension. How do you prescribe your medication that has been taken, and how do you improve the follow-up of that? Because that's a big challenge. Back again on communication, are people aware of the importance of taking the medication? Are they aware that I feel good but I still have high pressure? That's the risk. That's why communication, I think, is one of the important things. But this topic will be part of the hypertension workshop on how you make people follow up to the treatment and make sure that the pressure is low and you reach your target. Any other questions for now?
They may develop the same.
Yeah, that's true.
So how can we address
There are programs, if you want to stop alcohol, what you can do. There are medications you can prescribe in the period they stop. Usually as a doctor you need to know this medication because you had the patient in the hospital and before he was an alcohol, he was drinking a lot. Well, he's on an IV drip because of severe disease or anything. He will not take the alcohol, so you need to know what you prescribe. There are regimes for if somebody is on a high use of alcohol, what you can prescribe like benzodiazepines. There are clinics where they have whole programs how to take people out of this abuse. It's an addiction, so if people are really taking a lot and they stop once, then for sure they can get side effects. They can get a delirium, which is also quite risky, but still continuing is more risky. And so I think it goes beyond a little bit this program, but there are medication prescriptions you can advise if people are stopping with alcohol, or if they are admitted and they cannot take alcohol, but they used to take a lot.
Maybe to add more on what Kumar was trying to explain, there are some places or some well-developed setting where there are special programs for the alcohol cessation, smoking cessation program, and others like even the weight control program. But it's unfortunate that we don't have well-developed programs around maybe there may be maybe, but in some very source-limited setting like us, we have no specific programs. Like I can enroll my patients, maybe my patients in the specific program. So all we do is we we have the basics in schools, like knowing who is the problematic drinker, and then we have the graded way of reducing alcohol intake to harmful to the level that maybe if you reach certain level, someone sees taking alcohol. So it's like you start advising someone to reduce the intake to you just tap it down until someone can actually take it. There are some people that these programs are working, but there are people that are that's difficult. That's of course we can also think maybe later on our project we should also think if we can have a special program like the alcohol cessation program, smoking cessation program, or even the weight control program. Maybe that's we can take that as a challenge. Maybe later on in the course of our project, we can have something like that. That's what we can have the human resources and all the capabilities for that.
So nice for the next year.
Another question. I wanted to know this type 5 diabetes. And then do you mean that it is a replication during all the age or it is
Well, all the ages, I think it started in middle age, 14, 15. That's what I see. And I think it's recognized recently that it's a different problem. In the past, we've seen a lot of the group of people who grew up in the Netherlands, for example, in the World War II, when there was a lot of shortage of food. We see on those are the people we saw in the like an increase of diabetes, which we never considered it as a separate way of getting diabetes. We always considered it as a type 2. Now here in low developing countries, in Tanzania for example, there were we also saw that when there was shortness of food in some areas, later on you see more diabetes coming. And we see diabetes coming in people who have not have the traditional risk factors or do not have the, that's why we're really asking why and how. And it's new, so there's not much known about it. I saw the first articles, but it's now recognized as an issue to concentrate on, like what you, and they think it has also to do like the body is storing sugars and remembering that later on. But it's a new subject. But it's not a very old. I think it's the middle age who are suffering from it.
Okay, I think also Dr. Damas had something.
Yeah.
Welcome.
one of the drugs which to use or eliminate risk for potentially is exercise. And kind of exercises are more addressed aerobic kind of exercises. Which is cycling, cleaning out stairs, and jogging, and also exercise. We mentioned one was the exercise like doing things from the chair.
Yeah, for old people, for example. Yeah.
Those exercises
Yeah, there are a lot of programs to be found. A lot of old people have problems with walking, yeah? And that's my main patient group. At they're not able to walk alone, or they're only able to walk a little distance. So they might go every week to physiotherapy, but between that, they cannot only walk to the toilet with the assistance of a person. But still, for example, if you are depending on a wheelchair and you have problems with your fascias in your leg, if you do exercise with your leg in the chair, that's still better than doing nothing, and it's still reducing the continuation of the problem, but also that's the main cause. We know, for example, that peripheral vascular disease, walking exercise is one of the treatments. So somebody has a blockage in his leg, you can give him medication, but the first treatment is physiotherapy, is walking exercise, and then the body itself make new vessels and decrease the problem. But old people who cannot walk, you can still let them do those exercise in a chair, like stretching the leg, like we also doing some exercise. That will come more. I hope Mary will share. People will be very interested to know. I think what you can do.
Thank you. We have 2 questions.
Yeah, and then we go.
Then we go for tea.
More questions can come in the end also. Then you have here everybody, and you can also see. Maybe you can also interact on some topics which have a link.
Yeah. Maybe Tom, you have something?
I want to ask the shows that the people who smoke they have a low in smoking. Yeah, it means that they have low.
Yeah, it's related. So people are looking in a group like.
How do you compare, especially the environmental such as the area which is not built a winter? Most of the people like to smoke to make their body so that they can feel it and they will feel good when they smoke.
Yeah.
There's a lot of heat in them. Can we compare some environment and facilitate people to smoke rather than more economic?
No, this is what this is not like this is what they looked at, like and this is especially coming from research in Tanzania. The best way to reduce smoking, for example, that's why somebody also from the government is there, is making guidelines on where to smoke. The reduction of smoking on the Netherlands is on the moment reduced because there's hardly a place inside you're allowed to smoke. In all public areas you're not allowed to smoke. Or even in most of the pubs you're not allowed to smoke. If you're smoking you really have to look for a place. But here the high level smoking related with low level of education and poor economic status, this they took from screening people and asking, like, do you smoke, what's your economic status? And then they found more smoking in people who have had a poor economic status. And a low level of education. So it's just an observation, and it's a relation. So it doesn't mean it's the cause, because if you don't have money, usually you also have no money to smoke. But we see more smoking in people who have low education. That's what they found in this research in some of the data.
have something to add here.
Oh.
As this is because we are talking of Tanzania and sub-Saharan countries.
Yeah.
So poverty can bring a lot of stress,
especially these young age when they have less education, they can't get jobs, or they have nothing to go. Life is very difficult, so they are so stressful. So what they find themselves getting into habit of smoking, and they continue smoking, and that is also a high risk of tuberculosis because of the stress that is surrounding
Yeah.
them.
So the risk factors, stress and smoking are also related. We usually they go together, I think, what you mean. And that can be a main cause. That poverty is maybe one of the reasons of smoking. But, well, I thank you for your contribution. Bill, any questions? If you have any questions later on, we can still
address them in the end when all the speakers came. This is more a kind of an introduction. Or, I don't know, our host has been going down this because we can finish here. And then we go for now there's the prepared tea. The tea is ready. After this we come back here, but please look at the workshops which will be done after the next presentation. So you can, and some of the workshops will only be done in the morning or in the afternoon. So you really have to see that you're not prescribed on the locations.
Sao?